Bismillahirrahmanirrahim. Now we will continue from the sciatic nerve onward. I will highly recommend for all of you to listen to the dirty medicine mnemonics for the lower limb and as well as for the upper limb. They're like very good. So let's start. So sciatic nerve is the root value. The root value of sciatic nerve is L4 to S3. Then we have the innervation. The sciatic nerve is innervated. The motor innervation by the sciatic nerve to the semitendinosus, semimembranosus, biceps femoris, adductor magnus muscles. Okay, and then cause of injury is herniated disc, posterior hip dislocation, or maybe the hypertrophy of the piriformis muscle as well. Presentation is split into presentation of comments. It splits into common peroneal nerve and the tibial nerve. Uh, just give me a second. Let me bring the sketch dirty medicine pictures. So here we have it. The dirty mnemonic here is that it is L4 to S3 disc herniation or piriformis injury, because you can see that it is passing below the piriformis muscle. If it is injury to the piriformis, or if piriformis just gets hypertrophied or something and that starts compressing the sciatic nerve, so it can cause damage. Secondly, so they have written the the motor innervation, semimembranosus, tendinosus, biceps femoris, and adductor magnus muscle. The point I want to highlight is the sciatic nerve is basically two nerves which are moving together, and they split in the popliteal fossa or slightly above the popliteal fossa into common peroneal nerve and the tibial nerve, which we'll see later on. The cutaneous innervation of the sciatic nerve is to all of the leg plus foot except for the saphenous, the femoral branch. So the saphenous branch or the femoral branch, I guess I don't have a picture of that. Okay, so the saphenous branch is basically supplying the medial part of the leg. So with an exception of that, there is a femoral saphenous nerve over here and over here, which is supplying the middle aspect of the leg. All of the leg and foot is being supplied by the sciatic nerve, the cutaneous innervation per se. So let's come back. They are saying here common peroneal nerve. Now we are going to common peroneal nerve. Let me bring the sciatic nerve from here. Greater femoral cutaneous and then obturator sciatic. Yeah, there we have the sciatic nerve. So you can see that the area of supply of sciatic nerve is the posterior leg through and through, then the lateral aspect of the leg, and the lateral aspect of the foot as well. So because medial is being supplied with the femoral nerve. So let's see the muscles that are being supplied. So here you can see it is coming out of the greater sciatic foramen, and sciatic nerve is L4, L5, S1, S2, and S3, L4 to S3, right? Then the muscles which are being supplied are the short head of biceps femoris, the long head of the biceps femoris. So basically biceps femoris. Then we have long head of the adductor magnus muscle, semitendinosus muscle, semimembranosus muscle. Then it gets divided into tibial nerve and the common fibular nerve, which we'll see later on. So let's keep it till here, and then we go to the nerve. So yep. So common peroneal nerve L4 to S2 innervation. Superficial peroneal nerve supplies, because common peroneal nerve will divide into superficial and deep peroneal nerves. The superficial peroneal nerve is going to give the sensory innervation to the dorsum of foot, except the web space between hallux and second digit, which will be supplied by the tibial nerve, I guess. No, which will be supplied by the deep peroneal nerve. So superficial peroneal nerve supplies a sensory innervation to the dorsum of foot, except the web space between the hallux and the second digit. Motor is for the peroneus longus and brevis. The deep peroneal nerve provides sensory innervation to the web space between the hallux and second digit, and motor is to the tibialis anterior. Cause of injury, trauma or compression of the lateral aspect of the leg or fibular neck fracture. That is very important, because the common peroneal nerve is winding around the fibular neck. If there is any damage to the fibular neck, that will cause a damage to the common peroneal nerve. Presentation, PED, peroneal everts and dorsiflexus. So PED, and there was also for tibial nerve, we'll see that later on. So PED is that the peroneal nerve everts and dorsiflexus, if injured, dropped. So there will be no PED, right? So there will be foot drop. Foot drop will be seen, and along with that, do you remember anything in the upper limb that was causing wrist drop? That was radial nerve damage. Radial nerve damage in the upper limb was causing wrist drop, and the common peroneal nerve damage in the lower limb will cause foot drop, right? And the PED is the mnemonic for the common physiologic functions that a peroneal nerve will evert and dorsiflex the foot. And if it is injured, the foot will be dropped. There will be no PED movement. Loss of sensation on the dorsum of foot. Okay, foot drop inverted, opposite to eversion, and plantar flex opposite to dorsiflexion at rest. Loss of eversion and dorsiflexion, that is called a steppage gait. Steppage gait is characterized by the common peroneal nerve injury. Common peroneal nerve anatomy with the fibular fracture. if I could zoom it in, so here you can see that the fibula is being fractured over here. This is peroneal nerve damage, that means superficial peroneal nerve and the deep peroneal nerve, or maybe I guess there is some fracture somewhere. Okay, here is a fracture. If you could see, this is the fracture site. I have seen this picture somewhere. I don't remember where. I guess on the 100 points maybe. Deep peroneal nerve, the anterior compartment of the leg, whole muscle act as dorsiflexors of the foot. So deep peroneal nerve is supplying the anterior compartment of the leg, while the superficial peroneal nerve supplies the muscle of lateral compartment of the leg, which function primarily to evert the foot. So superficial peroneal nerve is for the eversion, while the deep peroneal nerve or deep fibular nerve is for the dorsiflexion. Okay. Before moving to the tibial nerve, I would like to see the dirty mnemonics for that. Sciatic common peroneal. So there was one thing that sciatic nerve is also damaged due to disc herniation. I guess we discussed that. Yeah, we discussed that. Okay, so common peroneal nerve L4 to S2 from sciatic nerve injury, lateral aspect of the leg, also known as fibular neck fracture, as you can see here. Then we have the common peroneal nerve gets divided into deep peroneal nerve and superficial peroneal nerve. The deep peroneal nerve will supply the tibialis anterior, okay, in the anterior compartment of the leg, while the superficial peroneal nerve will supply the peroneus longus and brevis, which are in the lateral compartment of the leg. The tibial nerve will come later on. Okay, so let's see the another pictures of that. The sciatic nerve, before that the obturator and femoral. So tibial nerve is over here, but we are not studying tibial nerve. Common fibular. Yeah, common fibular nerve is over here. Here you can see this is the common fibular nerve there, and common fibular nerve is coming down and it is binding around the neck of the fibula. So this is the area of cutaneous innervation by the common peroneal nerve. The common peroneal nerve, this is the area which is being supplied by the common peroneal nerve as a whole. The small area that is overlapped by the lateral sural cutaneous nerve, but that also is a branch of sciatic nerve. Then the gray area, this one, the gray area is being supplied by the superficial fibular nerve. You can see it is supplying almost completely the dorsal aspect of the foot, with an exception of this small area, which is supplied by the deep fibular nerve and the sural bilateral dorsal cutaneous branch. Okay, so this is cutaneous innervation, and for the muscle innervation, we have seen that the superficial one, the deep peroneal nerve supplies the anterior compartment. Deep is for the anterior and superficial is for the lateral. Okay, then tibialis anterior nerve, tibial nerve, sensitive to the sole of foot and motor, biceps femoris, long head, biceps shurai, plantaris, popliteus, flexor muscles of the foot. Cause of injury, knee trauma, Baker cyst, proximal lesion, Baker cyst, which is the proximal lesion, and tarsal tunnel syndrome, which is the distal lesion. We'll see both of them right now. And the mnemonic for this one is tip. For the common peroneal, it was pegged, right? And now it is for the tibial, it is tip. Tibial inverts and plantar plexus, if injured, can't stand on tiptoes. Inability to curl the toes and loss of sensation on the sole. The proximal lesion, in proximal lesion, foot everted at rest. The loss of inversion and plantar flexion. So if there is proximal lesion, that is in the Baker cyst, so there will be foot will be everted, okay, at rest, and with loss of inversion, there will be no inversion. Foot will be everted at rest with the loss of inversion and plantar flexion. Okay. Uworld point is injury to the tibial nerve at the tarsal tunnel may cause sensory loss of the sole with intrinsic foot muscle weakness. However, plantar flexion and inversion remain intact as the fibers innervating these muscle branch off more proximity. So remember the points, like proximal and distal injury may present differently, like the one we saw for the ulnar nerve. The ulnar claw hand was not very evident with the proximal injury. It was there with the distal injury only. So the same is here. Not same, but the difference in the pattern of distal and proximal injury is present in the lower limb as well. So here you can see that if the tarsal tunnel, if there is distal injury, so in the case of distal injury, the manifestations will not be very clear, just only sensory innervation is gone. But if the proximal lesion to the tibial nerve is there, then we find the everted and the everted foot and everted and dorsiflex foot, right? Everted and dorsiflex foot will be seen with the proximal lesion. So injury to the tibial nerve with the tarsal tunnel may cause sensory loss over the sole with the intrinsic foot muscle weakness. However, plantar flexion and inversion remains intact as the fiber innervating these muscle branch off more proximally. So here you can see the pain and numbness is over there. Then we have tibia and talus and calcaneus. So tarsal tunnel covered by the flexor retinaculum ligament, the nerve, artery, and vein pass through the tunnel. Posterior tibial nerve compression or irritation within the tarsal nerve can be there. Ankle jack. Before that, let's go to the. Okay, I guess we're done with the nerves. Not yet. Not yet. But we're close. Okay. So let's go to the dirty mnemonics first. So the dirty mnemonics about the tibial nerve. Here you can see that the tibial nerve is originating from L4 to S3 from sciatic nerve, and the injury can be either by the Baker cyst in the popliteal fossa in the back of the lower limb, and here you can see the Baker cyst is coming out from in the popliteal fossa where the tibial nerve can be compressed by the Baker cyst. And secondly, that is the proximal ligament, and the tarsal tunnel syndrome, which is therefore will be the lateral ligament, will be the distal ligament, as you can see here. So then we have like the muscles for popliteus plantaris, tricep surae, bicep femoris, and plexus. This is the mnemonic, the first mnemonic. The tibial nerve is supplied with the TIP, tibial inversion plantar plexus, and common peroneal extend everts and dorsiflexus. Okay, so there's the we'll see that at the end. Coming back to the tibial nerve lateral picture. So the lateral picture of the tibial nerve is over here. So tibial nerve provides a cutaneous innervation to the plantar aspect of the foot, while we saw for the common fibular nerve that was supplying the dorsal of the foot, dorsum of the foot. The tibial nerve is resided on the plantar aspect of the foot. Plantar aspect, yeah, plantar, I guess. Okay, then we have the sural nerve, and the yellow one is the, I don't know, lateral plantar nerve. Basically it is all from tibial nerve. Remember that it is all tibial nerve. And then we have like the muscles. So there are a lot of muscles which are being supplied with the tibial nerve. We are not supposed to remember all of them, but remember that it is on the posterior aspect. When the sciatic nerve divides, the tibial nerve moves posteriorly downwards, while the common peroneal nerve will twirl or encircle the fibula and will come to the anterior and lateral compartment of the leg. So posterior compartment of the leg are being supplied by the tibial nerve, tibial nerve, and the anterolateral compartment are being supplied by the common peroneal nerve. Then coming back to our picture about the ankle jerk reflex, both afferent and efferent limb of the reflex are carried by the tibial nerve. So for the ankle jerk reflex, it was root values are very important because they ask you about that. So ankle jerk reflex is mediated by S1 and S2. Firstly, secondly, the afferent and efferent limb of the ankle jerk reflex are carried by the tibial nerve. We saw a few pages back that the I guess here, yep, the knee jerk reflex, the patellar reflex, both the afferent and efferent limbs of the knee jerk reflex were carried by the femoral nerve, and the root value was L2 to S4. So these two reflexes are very very high yield in the lower limb. Moving to the superior gluteal nerve, the superior gluteal nerve, the root value is S4 to S1, L4 to S1. Innervation, motor innervation is by the superior gluteal nerve. It is not going to supply the gluteus maximus. It will supply only the gluteus medius and minimus along with tensor fascia lata. Cause of injury: iatrogenic injury during the intramuscular injection to superior medial gluteal region. Prevent by choosing the superior lateral quadrant, preferably the anterolateral quadrant. Okay, so basically this is the supposed buttock. So we have to divide this buttock into 4 quadrants, and we have to apply the injection in the safe area. Prevent by choosing the superior lateral quadrant, preferably the anterolateral region. So superior lateral and preferably this anterolateral region, like over here. So that is the safe area because nerves are not over there, and that will give us a high chance of going into the muscle. Then presentation is Trendelenburg gait. Pelvis tilts because the weight bearing leg cannot maintain the alignment of the pelvis through the hip abduction. Lesion is contralateral. That is very important. Lesion is contralateral to the side of hip that drops. To the side of hip that drops. Ipsilateral to extremity on which the patient stands. So if the suppose that this is the patient's one leg and here is the buttocks and there is the second leg, when the patient, and this is the patient's second leg, when the patient is moving, then he will stand on this leg. So what happens is that how should I draw that? I guess I don't know. Okay, so suppose that this is a normal posture of the leg, and this pelvis over here has dropped down. So this pelvis will move down. Okay, this is a very bad picture, but remember that when the person is standing on the affected side, the opposite pelvis will drop down, and that is why they are saying that the lesion is contralateral to the side of hip that drops. So if the left side, if the right side of the person is dropping down, so the lesion is on the left side. Remember this. Yeah, here is a good picture. So here you can see that when the person is standing, this side of hip is dropping down. This is the Trendelenburg sign. Trendelenburg Okay, yeah. So Trendelenburg sign, hip drop observed contralaterally. That is region is on this side, right? So the hip will be dropped on the opposite side. So that is Trendelenburg sign. Weakened gluteus medius cannot contract. So when the gluteus medius is not contracting, resultantly, this side of the pelvis will move upward and this will come down, and the gluteus medius lurch. Patient leans ipsilaterally to maintain the pelvis. Okay, so to maintain the pelvis level, because the pelvis, this was straight line and the pelvis is gone in this axis. So to maintain the axis or to align both the axes together, the person tilts to this direction so that the pelvis becomes straight. Patient leans ipsilaterally to maintain the level of pelvis. And this particular type of gait is called as Trendelenburg sign or Trendelenburg gait. Proper placement of the proper placement, if in the anterolateral part of the superolateral quadrant, it will spare the nerve. And if you are using any other quadrant that can involve weak gluteus medius cannot contract, that will result in the Trendelenburg sign or the injury to this one, the superior gluteal nerve. Inferior gluteal nerve and artery is over here, superior gluteal nerve and artery to deform as blah 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 blah, and superior gluteal nerve, gluteus minimus, and transversal data, and gluteus medius. Forget about all of that. Now moving forward, injection with given in superior medial part of the buttock, this superior medial part, because we are supposed to go to the superior lateral part. Injections given in the superior medial part of the buttock risk the injury to the superior gluteal nerve. Injections into the superior medial, inferior medial, and inferior lateral region of the buttock risk the injury to the sciatic nerve. So basically, superior lateral one, this quadrant is the safest quadrant. Now, if you go to the superior medial quadrant, we are risking the injury to what? Risk injury to the superior gluteal nerve. Injection to the superior medial, also this one, inferior medial and inferior lateral region of the buttock, risk the injury to the sciatic nerve. So if we go to this one, we are risking the superior gluteal nerve for sure. But if we are going to this one, because here you can see the superior gluteal nerve is in this region, but sciatic nerve has also started like here. So we can risk the sciatic nerve in superior medial, inferior medial, and inferior lateral. All of the three quadrants harbor or contain the sciatic nerve, so that can be damaged if the injection is given in any of the three quadrants, and superior gluteal nerve can be damaged in the superior middle quadrant alone, and the safest one is superior lateral. Then superior lateral quadrant of the buttock is relatively safe for the intragluteal injections, although the anterior lateral region is preferred. Then inferior gluteal, S4 to L5 to S2, inferior gluteal nerve. So I guess we have question 1 for that as well. Superior gluteal nerve, okay. Common bone sciatic number obturator. No, we don't have that. Okay, let's come back. Inferior gluteal nerve is inferior gluteal nerve. Inferior gluteal nerve is a motor nerve to the gluteus maximus. The injury is seen in the posterior hip dislocation and presentation, difficulty climbing the stairs arising from a seated position and loss of the hip extension. Pudendal nerve is Latin to be ashamed. Nerve supplied to the genital area. The innervation, sensory perineum, motor, external urethral and anal sphincter. Okay, so innervation, sensory innervation by the pudendal nerve is to the perineum, and motor innervation is to the external urethral and the anal sphincters, external anal and external urethral sphincter. Cause of injury, stretch injury during the childbirth. So during the childbirth, there is a bright chance of damaging the pudendal nerve. Presentation and comments. Decreased sensation in the perineum and genital area can cause fecal or urinary incontinence. Can be blocked with a local anesthetic during the childbirth with the ischial spine as a landmark for the injection. We use the ischial spine as a landmark for the injection, and we can give pudendal nerve anesthesia in this region, and the pudendal nerve anesthesia is not going to stop the uterine contractions or not going to stop the pain of the uterine contraction. The pain of uterine contractions will still be there. Pudendal nerve block at the ischial spine tip, used for anesthesia during the vaginal deliveries and for minor surgeries of the vagina and perineum. Suppose that we were doing the normal delivery of the patient, and we saw that the cranial size is not or the head size of the fetus is larger than the opening of the vagina, so we had to do some episiotomy. So in that case, we give the pudendal nerve block. Uterine contractions are still there, but episiotomies are for the vaginal or the perineal anesthesia, not the visceral anesthesia, if you may say that. Lumbosacral radiculopathy, and then we have psoas muscle, psoas abscess, sciatic foramen. Where do we have the lawyer? Okay, I'm sorry. So lumbar radiculopathy, disc level L3 to L4, weakness of the knee extension and decreased patellar reflex. L4 to L5, weakness of the dorsiflexion, difficulty in heel walking, and if disc level if L5 to S1 is damaged, weakness in the plantar flexion, difficulty in toe walking, and decreased Achilles reflex. So remember that the level of in the knee jerk, we saw that the root value for the knee reflex was L2 to L4, while for the ankle reflex it was S1 S2, right? So here you can see in this table that L2 to L4 is involved in this region. So if this is damaged, so plantar reflex will be gone. If L5 to S1 is damaged, Achilles reflex will be gone. And okay, then moving forward, lumbosacral radiculopathy. This is the table of Uworld. So if there is nerve root L2 is involved, upper anterior medial thigh sensory loss will be there in the upper anterior medial thigh, and weakness will be hip flexion due to the damage to the iliopsoas muscle. If L3 nerve is involved, lower anterior medial thigh will be involved, and the weakness will be in the hip flexion, iliopsoas, hip adduction, and knee extension, that is quadriceps. If the L4 nerve root is involved, so sensory loss will be lower anterolateral thigh, knee, middle calf, and foot, hip adduction, knee extension, quadriceps, and the plantar reflex will be lost. L5, buttocks and posterior lateral thigh and anterior lateral leg and dorsal foot, foot dorsiflexion and inversion tibialis anterior, foot eversion peroneus, and toe extension, extensor hallucis and digitorum. S1, buttock, posterior thigh and calf and lateral foot, hip extension, gluteus maximus, knee flexion, hamstrings, foot plantar flexion, gastrocnemius, and Achilles reflex. This is a very dry table, like dry the bone. So remember these things. Like you have to remember these things. Then lumbar radiculopathy, and they've shown that the foramen, it can be because of foraminal stenosis, L5 nerve is compressed, or because of a herniated disc and X1 nerve is compressed over there. Okay. Moving forward to the action of hip muscles. So these are the major flexors, and then we have the major extensors, major abductors, adductors, internal rotation, and external rotation. So first talk about major flexors. The major flexors are iliopsoas, sartorius, tensor fascia lata, and pectineus. The major extensors are gluteus maximus. Hamstrings extend the hip and flex the knee. Hamstrings are going to extend the hip and flex the knee. Semitendinosus, semimembranosus, and the biceps femoris. They extend the hip and flex the knee. So they are hip extensors along with gluteus maximus. And for the major flexors, we have iliopsoas, sartorius, tensor fascia lata, and pectineus. So any muscle that crosses both joints, the hip and knee joint, so that will flex, and that's not a rule, but that will be acting on both the joints. So here you can see that the hamstrings, they cross the both the joints, so they will be extending the hip and flexing the knee, right? And okay, let's keep it till here. Then we have major abductors. Major abductors are gluteus medius and minimus, and major adductor is adductor magnus, longus, and brevis, and other pectineus and gracilis. Internal rotation is caused by the gluteus medius, minimus, and tensor fascia lata, and external rotation is caused by the iliopsoas, gluteus maximus, and piriformis and obturator nerve. So make some mnemonic for that or something. Then okay, so let's try to make it. Major flexor, it is ISTP. ISTP. These are the initials, so you can make it like ISTP. Okay. Then we have GH over here. Major flexor GH, growth hormone. ISTNP. Okay. Then we have major abductor are GG. The major adductor are you may say AO maybe, or APG. Then the internal rotation is mediated by GGT, gamma glutamate transferase maybe, gamma glutamate transferase, and external rotation with the IGP. Okay, I'm very bad at giving mnemonics, so I'm giving you the initials which you could do by yourself as well. So do something about this, because you have to remember these things. Major muscle used in sitting up from the supine position include the external abdominal oblique and the rectus abdominis and the hip flexors. What is psoas muscle? Origin, anterior surface of the transverse process and the lateral surface of the vertebral body, that is equal to L5. Insertion, lesser trochanter of the femur, and function is hip flexion. Okay, then let's talk about psoas abscess. So risk factors: intravenous drug use, diabetes, and HIV infection, and from other forms of immunosuppression. Presentation: fever, back or flank pain, inguinal mass, and difficulty walking. Pain is exacerbated by movements that cause the psoas muscle to be stretched or extended, such as extension of the hip, that is psoas sign. Patients frequently position themselves to minimize the psoas stretching and discomfort, particularly with the hip flexion and lumbar lordosis. Sciatic foramen. The pelvic opening, serving as a major pathway for the pelvic neurovascular structure to the lower limbs, it is divided into greater and lesser sciatic phenomena by the sacrospinous ligament. Okay, the sacrospinous ligament is the one that is moving from the sacrum to the ischial spine. This is the sacrospinous ligament. So here you can see that there was a big foramen that is being divided by the sacrospinous ligament into greater sciatic foramen and the lesser sciatic foramen. The greater sciatic foramen, the contents of the greater sciatic foramen include the piriformis, the structure running above the piriformis, and the structure crossing below the piriformis. The piriformis muscle is this one, like I guess this muscle. Yes, this muscle is the piriformis. So the piriformis occupies most of the space in the greater sciatic foramen. Functions of piriformis externally rotate the thigh. Structures running above the piriformis include the superior gluteal vessels and superior gluteal nerve. Structures crossing below the piriformis include inferior gluteal vessels, internal pudendal vessels, and the multiple nerves, most notably the sciatic nerve. Here we have anterior superior iliac spine, then the margin of the pelvic inlet, and the pubic tubercle and rotulator foramen, blah 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 blah, a lot of that, a lot of stuff. So remember these three things in the greater sciatic foramen. Then we have piriformis syndrome. What's that? Muscle injury or hypertrophy can compress the sciatic nerve to cause a sciatica-like symptoms. For example, pain, tingling, and numbness in the buttock and along the nerve distribution. The muscle can be tender with deep palpation or on stretching with the adduction and internal rotation. So remember this thing that piriformis syndrome is going to affect the sciatic nerve and there will be sciatica-like symptoms. Common musculoskeletal condition. First one is iliotibial band syndrome. What's that? The iliotibial band, thick strip of connective tissue connecting the several muscles in the lateral thigh. So that is iliotibial band. Okay, iliotibial band. It plays an important role in the movement of the thigh by connecting the hip muscles to the tibia of the lower leg. Overuse injury, lateral knee, that occurs primarily in the runners. Pain develops secondary to friction of iliotibial band against the lateral femoral epicondyle. So pain develops secondary to the friction of the iliotibial band against the lateral femoral epicondyle. Lateral femoral epicondyle would be over here. So it can be friction. Friction can occur over here or maybe over here, because when a person is running, so this iliotibial band is stretching and that is causing strain on the lateral knee. So that strain can cause lateral knee injury that occurs in the primarily the runners maybe. Okay, so this is the iliotibial band syndrome. Then we have medial tibial stress syndrome. What's that? They're also called as shin splints. Common cause of shin pain and diffuse tenderness in the runners and military recruits, caused by the bone resorption that occupies the bone formation in the tibial cortex. So where we have the tibia, this is the tibia, I guess, anterior compartment, and then so anterior compartment, the muscles of the anterior compartment, when the person is doing sprinting or running something, so the tibia will be the tibial attachment of the muscle will be stretched. That may erode the periosteum, and if the periosteum is being eroded, so that will result in shin splints. Limb compartment syndrome. Compartment syndrome of both the limbs, upper and lower, is very important because there are the muscles and the neurovascular structures are divided into compartments which are lined by the fascia. So there is any kind of pressure that is increasing, any kind of mechanism that is increasing the pressure inside that particular compartment will cause the compartment syndrome by compressing the nerves and vascular structures present in that compartment. Increased pressure within the facial compartment of a limb, defined as compartment pressure to diastolic pressure gradient of less than 30 millimeters of mercury, venous outflow obstruction, and arteriolar collapse, that will result in anoxia and necrosis. So whenever there is increased pressure within the facial compartment of a limb, for example, this is the facial compartment, the red one, green one, purple, and the blue one, all of these are facial compartments. The compartment pressure to diastolic blood pressure gradient, if it is less than 30 millimeters of mercury, the venous outflow obstruction and arteriolar collapse will be there, and it will result in anoxia and necrosis. Causes include significant long bone fractures, reperfusion injury, and animal venoms. Significant long bone fractures, reperfusion injury, and the animal venoms can cause it. Present with 6 P's. Number 1, pain with passive stretch or out of proportion to the injury, paresthesias, pulselessness, poikilothermia, that is cold skin, pallor, paralysis. Motor deficits are late sign of irreversible muscle and nerve damage. So what are the 6 P's? Pain, paresthesias, pulselessness, poikilothermia, pallor, and paralysis. So remember these 6 P's in a compartment syndrome, either in the upper limb or lower limb. Diagnosed clinically or via Stryker device, needle apparatus that shows the increased pressure within a compartment. Then we have plantar fasciitis. So what is plantar fasciitis? Plantar fascia strain. Inflammation of the plantar aponeurosis, characterized by the heel pain, worse with first steps in the morning or after the period of inactivity and tenderness. Okay, so what is plantar aponeurosis? Plantar fasciitis means inflammation of the plantar aponeurosis that is characterized by heel pain, versus first step in the morning and after the period of inactivity and tenderness. Then we have decurvane tenosynovitis, non-inflammatory thickening of the abductor pollicis longus and extensor pollicis brevis. So what is that? The decurvane tenosynovitis is the a non-inflammatory thickening of the abductor pollicis longus and the extensor pollicis brevis. Tenderness characterized by the pain or tenderness of the radius at the radius styloid. Okay, so tenderness characterized by the pain or tenderness at the radius styloid. Positive Finkel stream test. Pain at the radius styloid with active or passive stretch of the thumb tendons. Treat with rest, NSAIDs, thumb spica splint, steroid injection, and surgical release. So here you have the tendon and then extensor pollicis brevis tendon, abductor pollicis longus tendon, and then we have the swelling over here, ganglion cyst. So fluid-filled swelling overlying the joint or tendon shape, most commonly at the dorsal side of the wrist, arises from herniation of the dense connective tissue. So these are the ganglion cysts. Childhood musculoskeletal conditions, developmental dysplasia of the hip. Abnormal acetabulum development in the newborns result in the hip instability and dislocation, associated with 4Fs, female, firstborn, fanny first, breech presentation, and family history. So female in 80% of the cases, then firstborns, developmental dysplasia of the hip joint. Then fanny first, which means breech position, breech presentation, and family history. Diagnosed clinically with a Barlow test, Ortolani's test, Lazy's test, Trendelenburg sign. Okay, so they're like horrible nightmares. Bellow test. What is Bellow test? Test to see that if you can dislocate the hip, flex and adduct the hip, apply light pressure on the knee, directing force posteriorly, test positive if posterior dislocation occurs. So we have to, in the Barlow's test, we have to check for the posterior dislocation of the hip, okay, or dislocation of the hip, flex and adduct the hip. We have to, okay, so person is lying comfortably, and we have to do what? We have to flex and what? And adduct the hips. Okay, move midly. So we have to flex and adduct the hip joint. Apply light pressure on the knees. Now we'll apply light pressure on the knees over here, directing the force posteriorly. Okay, not here, like this. Okay. Test positive if the posterior dislocation occurs. So if the posterior dislocation of the hip occurs, that is positive Barlow's test. I can't understand anything. Barlow. Okay, let's see if we get some small video for that. Here's one. Give me a second. So there we have a video in which they are explaining the both the signs, like Barlow or Ortolani signs, and then the other two are Trendelenburg sign and the Glazy signs are also being they gave a hint of that as well. So let's see this video. So there is an easy way to remember this one. You may check this video as well. This video is Barlow and Ortolangus congenital. What's the name of channel? Nabil Ibrahim channel is the channel name. So go check that out. So let's come back. So B comes before O. So the B for the Barlow and O is for the Ortolani. Okay, and then Barlow we are going out tonight. Okay, Barlow we are going to the bar tonight. We're going out tonight. So in the Barlow test, we'll be pulling the acetabulum. We'll pulling the femur out of the acetabulum. Okay, where can be popped out of the acetabulum with this maneuver. Ortolani, O is for the out. So once we are out, so we have to come back. So once we have been out, we now time to go home. So the femoral head is reduced back to the acetabulum with this maneuver. So remember these two things. Then in the Bartolani, we were pulling the acetabulum out. No, pardon me. We were pulling the femur out of the acetabulum, and in the case of Bartolani, we were pushing the femur head back into the acetabulum. The bottom maneuver identifies unstable hip that is in reduced position that the clinician can possibly locate. So this is the point where the clinician or the physician is going to perform the maneuver. In the Barlow test, the examiner will flex the hip at 90 degrees. The maneuver is performed by bringing the thighs to the midline, that is adducting the hip, and then doing this, what he just said. Okay, so he just applied the pressure on the knees, and due to that application of this pressure downwards, the head of the femur was out of the acetabulum. So it's not like this. Barlow test is considered positive if the hip can be popped out of the socket with this maneuver. The dislocation is palpable. Autolani test used to confirm the findings. So basically, Autolani test is the confirmatory test for the what test? For the Barlow test. For the Barlow test, the Autolani test is the confirmatory test for the Barlow test used to confirm the finding of the Barlow test. The Autolani maneuver is performed following the Barlow test to determine if the hip is actually dislocated or not. So for the Autolani test, what do we do? O is for the out for the Autolani. So if we are out, then we go home and we do this. Like, what do we do? For the Autolani test to see is reduced. Okay, lay the infant supine, flex the hip and knees 90 degree. Apply the anterior pressure on the greater trochanter using the index fingers. So gently abduct the hips using the thumbs. Should pop hip forward back into the acetabulum. Positive test produces a soft clunk with successful reduction. Okay, so this is the maneuver. We are not going to perform the maneuver in the step 1 exam. So if you don't want to remember this thing, that you have to flex and extend and abduct and adduct, blah blah blah. So remember that the Barlow test, the head is being moved out, autolining is coming inside, and then the positive clunk sign is the indicator that the test is positive. Okay. And that's a very good video. You may see it over and again. So we are doing abduction and pushing the thigh anterior. Okay, so you have to do the abduction and push the thigh anteriorly, and then do what? The test is positive. The palpable audible clunk is heard from the hip being used. Okay. Then there is a differential between them. Barlow test, hip started and reduced. Test will dislocate the hip. Autolani, hip started dislocated. Test will reduce the hip. Okay, so this line means that when we started, the hip was inside the position, it was reduced. And our maneuver, the Barlow test, dislocated the hip. In the case of Autolani, when we started, the hip was dislocated. And the test will reduce the hip. Okay, both tests are used for screening of the newborns. Then we have these tests are done for the what? These tests are done for the infants in the neonatal period. Neonatal period is from the birth till 28 days. Okay, they are examined one at a time, and usually the hips are flexed during these maneuvers. Okay, early diagnosis by the test are preferably with the ultrasound in essential to detect the hip instability. Okay, now we're moving way out of our league. So treatment is directed. Okay, so let's see that as well. So they're saying that ultrasound of the normal reduced hip looks something like this. Okay, so the radiologist will tell you that this is the line of axis of acetabulum and maybe iliac bone and something. So the femoral head must be over here. Like it must look like something like that. Baseline indication, inclination line, roof line. So it goes like that in an ultrasound of a dislocated hip. So here you can see it is going upwards. Okay. Treatment is directed at stabilizing the hip that has positive Barlow and Autolani sign. You have to stabilize that. First born female with breech presentation, Fanny first, and a positive family history are at risk of development of the are at risk of developing the developmental dysplasia of the hip, that is DDH. Okay. If the hip remains dislocated for weeks, these two tests are not reliable. Okay, Barlow and Autolani tests are positive after 3 months because are not positive after 3 months because soft tissue contracture around the hip joint will not cause these tests to be positive. Limitation of the abduction become most consistent clinical finding. Okay, this is the point. Children older than 12 months will have other findings which include the asymmetry of the hip abduction, a positive tendon and brigade, and a positive Glasgow sign. So let's come back. That's a very good video and you must see that. Coming back. In the Autolani test, we test to see if you can reduce the hip or not. Usually done after the positive Barlow's test for the confirmation. Lay the infant supine, flex the hip and knees at 90 degrees and apply the anterior pressure on the greater trochanter using the index finger. Gently abduct the hips using the thumbs. Should pop hip forward back into the acetabulum. Positive test produces soft clunk with successful reduction. Hip flick not specific. Both tests no longer positive after 3 months due to the soft tissue contracture around the hip region. Limitation of abduction predominates instead. Glazes test. Hip flex to 90 degree. Knee. I'm sorry. So for the Glazes test, you have to flex the hips At to 90 degrees, okay, flex the hip to 90 degrees, knees flex until the heel approaches hamstrings, and test if the knees at unequal heights, dislocated side lowers, apparent shortening of the femur. Okay, I guess this was the Glazes maneuver. This one, I guess, yeah, this is the Glazes maneuver. That both the knees are flexed and the heels are brought all the way down to the hamstrings, and this one is lower. This side is lower. So they're saying that hip flexed to 90 degrees, knees flexed until the heel approaches the hamstring, and test if the knees at unequal heights, dislocated side lowers. Okay. So remember that in the Glazes sign, the dislocated side is lower, while in the Trendelenburg sign, the older patient ambulatory pelvis dips to the contralateral side when the patient stands on the affected leg. Also occurs in the superior gluteal nerve palsy, but caused by the adductor muscle insufficiency as well. Confirmed by ultrasound, X-ray is not used until about 4 to 6 months because cartilage is not ossified. Treatment varies with age, less than 6 months. Pavlik harness keeps hip flexed and abducted. Avoid abduction more than 60 degrees. Risk of avascular necrosis. 6 to 15 months, hip spica cast for the treatment. Okay, and 15 to 24 months, open reduction followed by the hip spica cast. Prognosis is best with early treatment. Complications include joint contractures, avascular necrosis, risk of femoral head. Okay, then we have. Okay, so we'll do it, and we are close to physiology. Let's come back. So here is a picture of Barlow maneuver and Ortolani maneuver. So Barlow is like an evil doctor who is pulling your femoral head out of the acetabulum. So the examiner abducts the hip while applying a posterior force on the knee to promote the dislocation. So he is dislocating it. He did it again. Call Dr. O. So Dr. O will come, and Dr. O will cause its A back in. So examiner abducts the hip while applying the anterior force on the femur to reduce the hip joint. So that's bravo. So Dr. Barlow dislocates the hip, and then we have to call Dr. O to relocate the hip. What is Glazy test? Unequal height suggests the developmental dysplasia of the hip and the short femur. And this is Pavlik harness, which looks something like this, and then hip spica cast is looking like this. Then we have leg clavicular disease. Okay, that's horrible. Idiopathic avascular necrosis of the femoral head. Okay, so avascular necrosis of the femoral head due to idiopathic reasons. Commonly present between 5 to 7 years with insidious onset of hip pain that may cause child to limp. More common in males, that is 4 to 1 ratio. Initial X-ray often normal. So initial X-ray may be normal, but later on that may present with a leg clavicular disease. We'll keep it till here, and then we'll continue from the slipped capital femoral epiphysis in the next session. Until then, Allah Hafiz, Bima Allah, and